Hi, everybody. I'll try to make this motivational and not depressing. I wasn't, I wasn't sure what to call it, and then I had a great idea because in January of last January, I fell down some stairs outside of my house and ended up having to get surgery on my knee, and it was kind of a stupid thing. I did a lot of things wrong. I had put railings outside where the stairs were. It didn't look icy, but of course I had something in my hand when I was going down the stairs, so I wasn't really holding on to the railing, or I could have prevented the whole thing. And in one of the slides, I said something about thinking about, what I meant was think about what could happen. But so the whole reason I was going down the stairs was I had a door that I could have gone right outside on, and I wouldn't have had to go down the stairs, but the lock didn't work good, and it was just kind of a old crappy door. So instead of fixing the door, I decided to start walking up and down the stairs outside to my hot tub, which was another stupid thing. So I guess that was a good example of things that we should think about. And then subsequent to that, I had to wear a brace on my leg for 12 weeks. And so the kids made a big deal out of making sure my car was in the garage, which I had the garage all cleaned out, but I hadn't been parking the car in the garage in the winter. And I'm like, that's really stupid too. So one of the slides I talked about thinking about things we could do to make our life safer. So that's how I came up with the idea for the title. So this is just kind of a definition of aging. I guess it's not that important, except I think the important thing is to remember that there's changes that happen due to our age, which we may not feel them. We might feel fine. I think I talk to people all the time, and they're like, well, my balance is good, and I don't have to worry about falling, and I can climb a ladder. But there's actually physiological things that happen that can be measured that affect us even if we're perfectly healthy, if we don't have any disease processes. So under aging, it's time sequential deterioration. It happens it's inevitable in most living organisms, and it makes us more susceptible to disease, environmental factors, loss of mobility, agility. And it says that the factors affect the level of function become important when it crosses a certain level, depending on two factors, the rate of the deterioration and the level of performance needed. I think what that means is, as we get frailer, if we have an unexpected event, like I had to have surgery, or you get sick or get septic, that's when your level of performance may need to be higher, and depending on how far our physiological state is deteriorated, it can become an issue. I think one idea would be to keep our level of performance needed on a daily basis higher. So staying active, exercising, moving. I think if, unfortunately, when we get to this stage where we hardly leave the house and we are confined to the home, and that level of performance is pretty low, and we probably won't be able to respond to an increased level of performance if it's needed urgently. It said the critical difference is not in the level of the resting performance, but in how one responds to the external stress. But again, I would try to keep our resting performance as high as we can so we have some reserve. Get rid of that one quick because it can be depressing. So the mechanism of aging, basically there's accumulation of damage. It's a degenerative process. It talks about failure of our DNA and errors in DNA, superoxide radicals. The point is that there's things going on that we can't control that cause some damage to some of our systems. Luckily, we're built with reserve. So I guess the positive thing about this is this probably starts at age 40. So we already been going through it and don't even know it. It was interesting though, because I saw in today's paper that the oldest was a woman. The oldest person in the world was 117, and she died. I think she was born in the U.S. but ended up living in Italy. So they put something in there about olive oil. I don't know if that's the... But there was some doctor that was studying her, and he did say that she seemed to have some genes that helped her DNA repair systems work better. So a lot of the things we see with aging and a lot of cancers that start to occur when we get older is due to mistakes that our body makes because it's constantly repairing and getting broken down and repairing. and eventually some of the repair mechanisms make mistakes. Cell senescence, that's just kind of a new thing in aging, where cells, instead of, they stop dividing, and then instead of dying, they kind of just hang around and they kind of cause trouble. They secrete substances that cause our immune system to get activated. It kind of causes scar tissue, causing further inflammation. When you get people our age get an MRI or CT scan, they'll always say microvascular disease or white matter microvascular disease, and that's normal. But a lot of that is probably from what they call the hyalinosis of the blood vessels, the very tiny blood vessels that get way up in our brain. They're probably the size of a thread. As we age, some of this cell senescence kind of plugs them up. But you'll see now with patients having access to charts, when we do a CAT scan or an MRI for some other reason, they put that on everybody's. But it's probably a good demonstration of aging. The problem is people can see that before we get to explain it to them, and they get pretty freaked out. So physiological changes, we all know that about vision and hearing. I think it's important to remember, part of the hearing system is our balance center, the vestibular system, which is kind of like our gyroscope that tells us when we're moving, when we're going to fall. It's what makes us dizzy. So that plays a big part. Again, we lose cells in that system. Sometimes the signal coming from our gyroscope is delayed, so a younger person may realize right away they're starting to go down. The rest of us are halfway down before it occurs to our body to respond. Skin changes are important. We don't sweat as well, so temperature extremes, being careful, hot and cold, but hot weather, we don't sweat, so we're more prone to heat injuries. The skin thins out. The reason you get all the bruising is the dermis and epidermis are kind of locked together, and with age, with atrophy, it kind of gets smooth. So now your skin just slides like this, and it breaks the capillaries. That's why you see you just touch something and your skin bruises or tears. But it's important too if we become immobile from an illness or a hospitalization, because with the thinning of the skin and the loss of the subcutaneous fat, we're more prone to breakdown of the skin. You have to keep moving around, use a low pressure surface, but it can even happen to people that are home, that get COVID or get pneumonia, and they're laying around for a week. You have to be aware of those kind of things. Keep moving, keep pressure off places. Skeletal changes, obviously we all know about arthritis. The cartilage in our body doesn't repair itself like bone does, so as the cartilage wears out, we start to get bone touching bone, and you get bone spurs, and that's really what causes osteoarthritis. You can pay docs to inject stem cells into your knee or hip in the hopes of regenerating cartilage. It doesn't. I don't think it works yet, because we can collect the stem cells and put them in there, but we haven't figured out how to trigger them to actually make cartilage. There is a lot of good research and results though with stem cells being used, like in the pancreas for diabetes, and some research in Parkinson's disease trying to reproduce the cells that are gone to make dopamine again. With our heart, we have less ability to raise our heart rate. I think the most important thing is we have less ability to increase our ejection fraction. That's the amount of blood that comes out when the heart squeezes. So when we're sick, we get a fever, we bleed, we have an infection. We want the heart to be able to increase the output. That's somewhat blunted as we get older. Again, that's why I think a training effect of staying active, walking and exercising, can try to preserve our ejection fraction and make us able to respond to stress better. The lungs, just through aging, not through disease, we lose a little bit of lung function every year. It's called our forced vital capacity, but it's the amount of air our lungs can hold. What happens in smokers is, instead of losing a few cc's of volume every year, you lose a lot. So sometimes we'll see smokers quit smoking after 20 years and then 10 years later get a bad pneumonia or bronchitis, and the next thing you know, they need oxygen for the first time in their life. That's really because we have a large reserve, but if you use it up too quick, then the normal aging process where we use a few mLs every year ends up cutting into what we need to survive. I put GI on there. I think it's important to realize that things are slowed down. But when we take medications, they're fully absorbed. They just take longer to get in there. When doctors dose your medications, they are supposed to take into account that the liver, there's two systems in the liver that metabolize drugs. One of the two systems, which is what most drugs utilize, we have to alter the dosing to accommodate for that. So you could have higher drug levels if it's not being metabolized as quickly. So hopefully when your doc gives you drugs, they start low. I'll say start low and go slow. Under urinary system tract, we all know we're more prone to, men and women are more prone to bladder infections. But the kidneys also lose kidney function. So I have people call me up again when they see their labs before I see them, and it says their GFR, that's your glomerular filtration rate, is reduced. And I always have to explain to them that's because it's a calculation based on your blood work. So your blood work could be exactly the same, but part of the calculation adds your age. So when you add the age in there, it lowers your GFR, because we know that just through the normal aging process, the kidney function slowly declines. Again, it's important to take that into consideration with medications we use. Sometimes we want to avoid pretty common medications like anti-inflammatory drugs, ibuprofen, Aleve, etc., because as your kidney function declines, that can harm the kidneys. Immunological is important. That's our immune system. It kind of gets lazy when we get older. If you're exposed to a pathological organism, your white blood cell count is slow to respond. You may not run a fever. So it's sometimes we see one of our elderly patients with what we think is an infection. We can't. We shouldn't be reassured just because they haven't run a fever or they don't have a white count. You still have to be aware that they could have a serious underlying infection. That's why immunizations are so important when we get older, because of the problems with our immune system. Neurological, I think I have another slide on that, but we all know we lose brain cells. And so frailty is sometimes unavoidable, but that's pretty much when we've got to the point where we're using our full physiologic capacity just to kind of get by on our everyday activities. And what happens is, due to age-related changes, if you get a big stressor like an infection, operation, bleeding, you're not able to respond to the stressors. So again, I think one thing we can do is try to keep our everyday level of fitness as high as we can, so that we do have some reserve. And I think sometimes that's impossible. We get to a certain age, and then we just have to be smart about trying to keep ourselves out of trouble. Immunizations, don't fall. It's manifest by weakness, weight loss, decreased physical activity, poor endurance, and slowing of performance. And again, in many patients, because of other diseases they have that might be inevitable, but it's just kind of a marker that we really need to stay on top of those people. Don't let anybody sick go around them. Don't let a surgeon near them. Changes in cognition, balance, emotional health, falls, trauma, depression are all problems once we get to the frail stage. Then this is just mortality causes an elderly. So it's the heart disease, cancer, stroke, chronic lung disease. Actually, those are the same as all adults, so it's not that much different in the elderly. The infections, though, that's much higher up the list in the elderly than it would be in younger people. That's why I think we have to be smart about immunizations, have to be smart about exposure. It's okay to, if somebody's granddaughter has COVID, to miss her graduation or whatever. Masking, I think, is important. Again, when you're younger, you can kind of be laissez-faire about infections. I don't think we should be. Alzheimer's disease is a leading cause of death in the elderly, and then people always ask me, what do people die from? How does Alzheimer's disease kill you? Actually, it's the immobility. It's pneumonia, bed sores, that kind of thing. So mobility is really important. If you're not mobile, you're really prone to pneumonia. If you're not getting out of bed, moving around, breathing deep. We talked about, skin breakdown if you're immobile. diabetes it's the complication of diabetes. So tight control of diabetes probably is important to prevent complications 20 years from now. So the people that have the diabetes complications, it's really from having diabetes for a long time. As we get older, we can back off a little bit on diabetes control because we're not worried about complications 20 years from now. I guess maybe if you're going to live to be 117, but kidney disease, again, that's usually a manifestation of not taking care of your blood pressure or your diabetes. And then I think the big one is falls and accidents. Again, that outside of car accidents, that wouldn't be on the list of younger people, so that's a huge problem as we age. Falls just go way up, and the complications are devastating. So we know just through normal aging process that we lose neurons and dopamine. And Parkinson's disease, obviously, it seems to be more concentrated in a certain part of the brain, but everyone loses neurons and dopamine. There's a decline in the number of nerves and nerve fibers, brain atrophy. Slower conduction of nerve fibers across the synapse. So that's when, the nerves are like wires, but they have to be joined every so often. And where they're joined, there's a little space there. And acetylcholine it's a chemical, but that's the main neurotransmitter. So that if that's slowed, you can imagine, again, if you know that you're falling and your brain tells your leg to move or whatever, it takes longer for the incoming sensory nerve to tell you that you're about to fall or you're starting to tip over or you're tripping. And it also takes longer after your brain realizes it and tells your leg to make a certain move. It takes longer to get there. So those are measured things. That's what I said. People might feel steady on their feet, but then when you ask them, when did you last fall? And they said, well, last week and the week before and the week before. Then I'm always like, so I run every day, and I used to run out in the dark and the ice with Pat. I don't know, the last, you go 10 years, and I fell one time because I didn't have a light and fell on one of those big clunkers. But it's amazing. So just people doing their everyday activities start to fall, and it's a huge problem, and it causes a lot of health issues and a lot of deaths. So a modest decline in short-term memory occurs. It's not Alzheimer's disease. Alzheimer's disease is when you have, trouble learning new information, when you have trouble living independently. And the central integration thing is just, again, how all the nerves connect together, talk to each other. So they're not things that we feel, but we can measure them in the lab and show that they're delayed. So some things to think about with falls is, obviously working on our strength. Vestibular function is affected. We talked about that. It doesn't hurt to do balance exercises. There's lots of things you can do safely from a chair. A physical therapist can talk to you about that. There's lots of data that shows if your vision is off or you have cataracts, if your hearing is off, fixing those things reduces the incidence of falls. There's some studies that have been called into question that showed that not correcting hearing loss increases the chances of dementia. The most recent study says it probably doesn't, but we know part of dementia is lack of socialization or whatever. So if you can't hear, you kind of sit in the corner and you're not part of the conversation. So I think it's really important. Those are easy things to fix. Cataract surgery is usually uncomplicated. And almost anybody could have cataract surgery. I guess if you can't lay still or something, you couldn't, but it's not a major operation. And I think it's pretty important. Footwear obviously is important. I have people come in black and blue from head to toe, and they're like, I did what you told me not to. I was wearing flip-flops. Orthostasis just means when you stand up, your blood pressure can drop. That's very common in Parkinson's disease, and it's one of the hallmarks. So normally when we stand up, because of gravity, if we've been sitting or standing, the blood goes towards our lower extremities, and for a minute, there's less blood returning to the heart. So when the heart pumps, it pumps less blood. Your blood pressure will drop a little bit, and you kind of feel lightheaded. You have to be careful. You have to move slow. Like we usually say, stand up and don't go anywhere for a minute. That way, if you're lightheaded, you can sit down. The orthostasis doesn't kill anybody, but if you pass out and slam your head and break your neck or have a subdural hematoma, that can kill you. And we talked before, it can happen to anyone. It's exaggerated in Parkinson's disease. But again, the whole thing with the heart, not being able to increase the heart rate, or the ejection fraction. Those are two things that are normal compensatory mechanisms when we stand up that are blunted. Being distracted, not watching where you're going, keep an eye, watch where you're about to step, I think is important. Impatience, a lot of times you probably need to take 2 trips, downstairs so you can hang onto the railing. Instead, we want to do it all on one trip, or we carry too much. The location, again, I think if you have to be really careful if you're in an unfamiliar location, you're visiting somewhere else. You're going outside instead of on a flat surface. And then I put incontinence. Bathrooms is a big place for falls, one of the, probably the most common place in the home. A lot of times that's because, we're rushing to go to the bathroom. I think you have to figure something out if that's you. Nothing wrong with a bedside commode. Time to, go in and make yourself go to the bathroom even if you don't have to go occasionally. So, surface is important, making sure things lit. Railings only work if you hold on to them, have a good grip on them. I learned that one. And I, was thinking about the other day, there's stairs everywhere, they're dangerous, but, going up, you're probably not going to get hurt so much, but going down, you got to stop at the top and think, how am I going to do this? And I think if it's slippery or you're not sure, there's nothing wrong with doing one step at a time and let whoever you're with go ahead. Don't be impatient. Don't be in a rush. Rugs people trip on. Pets are huge, right? We all know people that have broken a hip from their little dog running around or someone else's little dog running around. They're good companions, but have to be really careful. I put hands-free, again, don't have something in your hand that you're so... I have patients that tell me they throw the laundry down the stairs, because their laundry's downstairs, unfortunately, and then they walk down, so they can hold on to the railing. And then assisted devices, if you should be using a cane or a walker, use it. When I had a cane, it was great. Everyone got the heck out of my way, and the other thing, if it makes you feel better, is there's lots of people who should have a cane, don't. With your cane, you just pass by them going, twice as fast as they are. But I don't think it's anything to be ashamed of. And I see people in the office, I'm standing at the counter, and they're one of my partner's patients, or I would lecture the patient, but they're coming by and they're holding on to the table over there, and then I have to move out of the way because they're holding on here. And I'm like, that person needs a cane. They're creeping, and it's like in the doctor's office, come on, somebody needs to talk to them. But people probably have talked to them, and people don't like to use canes. So I put down drug reactions because, there's some studies that show that a large percentage of hospitalizations are related to drug interactions, and they're preventable. I'm just making sure I'm doing okay time-wise. So actually, I did put an article out there. I wrote an article a couple years ago about how to reduce drug use. So, in the old days, polypharmacy meant if you were on more than 5 or 6 medications, that was polypharmacy, because the studies show if you're on 5 or 6 medications, there's about a 40 or 50% chance that those drugs are interacting and causing adverse reactions. But nowadays, I don't think you can use that definition. That's pretty random. There's some diseases like diabetes, or if you have heart disease, that's for heart disease, you might have to be on aspirin, a statin, a beta blocker, and so. But I think the definition is more drugs than are necessary for the patient's individual conditions. But they've been related. They're one of the major factors in falls, confusion, orthostatic hypotension. So the drug classes that are probably the most responsible for hospitalizations due to adverse drug reactions are the anticoagulants, the drugs we used for blood clots. That can be aspirin, it can be warfarin, it can be the new Eliquis drugs. So they are unfortunately necessary in a lot of situations, but I guess, again, I would ask your doctor or whatever if they need to stay on it. Certain conditions like atrial fibrillation are chronic, but sometimes you get put on one because you had a blood clot in your leg, and maybe it was 2 years ago, and no one's ever bothered to tell you that, we can probably stop that now. So I think you got to look and ask yourself why you're on the medications you're on. Low blood sugar. So again, the American Diabetes Association does not recommend real tight control for diabetes when we get older because low blood sugar can cause brain damage and kill you in minutes. And high blood sugar, again, when we're treating high blood sugar, we're really trying to prevent complications 10 or 15 years out. So there's medications now that we try to use that will normalize blood sugar without causing low blood sugar. And then I put deprescribing. So again, how can you get rid of some meds? There's, what I say, it's symptom drugs versus disease modifying. So if you've had a heart attack and you have a stent, your doctor's going to say you need to be on a statin drug, a cholesterol medication. That makes sense. An aspirin. But symptom drugs are, what we take for pain, what we take for urinary frequency, what we take for anxiety and depression. So those drugs usually, you can, obviously talk to your doctor, but a lot of them can be a trial of discontinuing, and a lot of times they were prescribed 10 years ago. We never tried stopping them, and when you stop them, you feel the same. So it's easy to judge symptoms, and they're not disease modifying. They're not going to, if you stop a statin, it might increase, and you have heart disease, it might increase the chances of having another heart attack. That would be disease modifying. But symptom drugs are usually things you can try stopping to see if they're helpful. If you're not sure, you stop them for a couple weeks and restart them and see if they made a difference. When I was at the nursing home, I would get, 3 o'clock in the morning, I get a phone call from the nurse. She was all, they're proud of themselves. I just found Mrs. Jones wasn't taking 5 of her medications. Can I start them again? This is at 3 in the morning. I go, well, how's she doing? She's doing great. How's her blood pressure? It's great. I'm like, get rid of them. So we actually had we did a drug holiday thing at Loretto where one day a week we would hold certain medications, but we had a list of ones. Again, you're not going to hold the blood thinners or seizure medications, but we did that because there's lots of evidence that these drugs tend to accumulate in time because of some of the things we talked about, like your kidney function, your liver function. So, there's, and I put an article out there, but again, drugs, you can think about, make sure you know what you're taking. There's a lot of patients who aren't even sure what they're taking the drug for, which is understandable because we use all these different names or whatever. But sometimes it might be something like, I'm taking it for heartburn. I don't even have heartburn. Your doctor might say, let's try going without it. So that was the other thing. I always thought it was kind of a pain when I first started in the nursing home like 20 years ago. But we had to, if we ordered a medication and there was no diagnosis, the pharmacy wouldn't fill it. And I realized that because to make us think about why is the patient getting it and make sure. I still see that sometimes where I see someone on something dangerous like a blood thinner and I can't find the diagnosis of why they're on it. So I think that's a good concept to make sure you know what you're taking each medication for. Primary prevention versus secondary prevention. So when you've had a stroke or a heart attack and we want to prevent that from happening again, that's secondary prevention. Those drugs are probably pretty important. Primary prevention is, I've never had a heart attack or a stroke. I have high cholesterol. At some point in your life, it might be worthwhile to try to stop that. Again, even with statin drugs, you're probably looking at a 5 or 10 year period before you would see the benefit from it. So those are drugs that sometimes we would look at to try to discontinue. Drugs that are duplicative, if you're on 3 blood pressure medications and every time you go in, the doctor says, your blood pressure looks very good, you might be able to ask him, can I stop one? We did a study when we were at Loretto, and again, people had been on the meds so long. We took people that are on multiple blood pressure meds, and it's easy enough to stop one of them, and you can measure your blood pressure, so it's pretty easy to tell if it's okay or not. Then I think it's important with treatment goals when you're taking medications. Are you should talk with your family and your doctor, but, are your priorities to live as long as you can, or are they to be I just want to be happy and I don't want to be sick to the stomach and constipated? Because that will help us decide what the best medical regimen for you is. This is just a list of potentially inappropriate medications. So again, we said the kidney and liver changes affect metabolism and half-life of the drugs, so we have to be careful how we dose them. As we age, we have less lean body mass and more higher body fat percentage. Some drugs are bound to protein. We have less protein made by our liver, so the free portion, the active portion, would be higher. So those are all things that we take into consideration. I think the big thing is the anticholinergic drugs like sedatives, narcotics, antihistamines. A lot of the older bladder drugs were affected the anticholinergic system, and that again is the chemical in our brain that is a neurotransmitter, and that's the drugs that we use for dementia are actually trying to boost up the level of acetylcholine, and these drugs actually lower the levels. So there's a bunch of drugs that we would try to avoid. Like, we don't usually recommend people take Benadryl, which is an antihistamine. We'd recommend taking one of the newer drugs like Claritin or Allegra or something like that. Again, I would look at the anticoagulants if they're still necessary. Again, there's newer insulin, is, believe it or not, is on the beers list, short-acting insulin. Because what we find is doctors are too aggressive in treating diabetes. They're causing people to get hypoglycemia. Some people die. So they're suggesting that most diabetics, as we age and we don't need really tight control, we can avoid short-acting insulin. We can sometimes avoid insulin. So I think we kind of talked about those. The lag phase just means, am I taking it to prevent something 20 years from now? Do I still want to be around here 20 years from now? Risk-benefit ratio, there's side effects to everything, and you can find out if have a discussion about whether the drug might be benefiting you. And then, so I basically said, what can we do? So this stuff's been going on since we were 40. We didn't even feel it. So I would say, instead of, having a negative attitude about getting old, there's things we can do. So don't sit still. Have a positive attitude. Socialization is really important. Don't sit at home. If you have to join a club or go visit with family, but don't say, no, I'm too tired today, I don't want to go. Manage your chronic medical conditions. There's some conditions that we actually need to take medicine for, and if it's your blood pressure or whatever, try to be compliant with your medications. Sleep is important. When we get older, the studies are kind of variable about whether we need less sleep when we're older, which a lot of people say. Whether we don't, we probably don't need less sleep. We sometimes get less sleep. So what we do know is, when you sleep, you're in a much lighter phase of sleep, so very small noises or heat or cold or whatever will kind of wake us up. So we tend not to get 7 hours in a row. We might get 2 or 3, wake up 2 or 3, might need to, there's nothing wrong with taking a nap during the day, unless you're trying to reset your bedtime. If you're going to bed at 6 o'clock at night and you want to start going to bed at 8, then you probably shouldn't take a nap. So we probably do need the same amount of sleep. We might have to get it in, fragments. I just said control your environment. Again, think about where you're going. Can I avoid going down these stairs by taking the elevator and going out the bottom floor? If you got people that are pushing you to do stuff, then make them help you. And then, of course, nutrition, alcohol, and tobacco are all important. Alcohol goes a lot farther in the elderly than it does when you're younger. So be careful. I think that's all I had, and I think I'm out of time. But Pat knows how to get a hold of me if you got questions and stuff like that. He can email me or whatever. So hopefully I wasn't too depressed.